Topic is entitled ACE inhibitors, ARBs, sacubitril, valsartan, beta blockers, which and when in patients with STEMI, and brings up really, I think, an important point, and that is the whole issue of new trials of old drugs. And this comment made by Green in 2019 is quite challenging. Should evidence come with an expiration date? Is there an evidentiary statute of limitations? Should we be using drugs that were proven to be effective 30 or 40 years ago? Are they still as effective in the current era? And do we have to relearn some of the old lessons? And in this paper by Stuart Pocock, the statistician, and myself, we discussed the need for new trials of old therapies, and particularly amongst those are the role of beta blockers after myocardial infarction or coronary revascularization, the trials of ACE inhibitors and ARBs after myocardial infarction and acute coronary syndromes, and now the issue of sacubitril valsartan. I think it would be difficult to convince people to fund some of these trials, but trials that are really important are treatment withdrawal. If I go back and think of the trials of ACE inhibitors, these are 20, 25-year-old trials. They were very successful. But 25 years later, our patients are older. Their renal function has diminished. They're on multiple other drugs, and there may be drug interactions. So should we be saying that because you started on a drug 20 years ago at a time when trials showed it to be very effective, should you still be continuing? Or could we be seeing a downside of that drug or a loss of effect? And this is another question for another day, and that is the trials of ICDs in the primary prevention of sudden cardiac death are also 20, 25 years old, many of them. And we now have shown that with the advent of many of the new drugs that the sudden death rate in heart failure is declining. Would those trials still be as positive? But that's for another day. Now, LV remodeling, to begin with ACE and ARBs. This is the slide I showed you before, Dr. Mark Pfeffer. After a myocardial infarction, one gets an area of infarct expansion. That alters the Laplace relationship of pressure, tension, pressure and radius and wall tension. That then leads to global remodeling and dilatation of the entire ventricle and heart failure. And the pivotal work done by Dr. Pfeffer and his wife, Janice, the late Janice Pfeffer, in both the animal lab and clinically, showed that angiotensin converting enzyme inhibition was highly effective in interfering with this process and reducing the end result of mortality and heart failure. And so we have a whole series of trials. The first trial was Pfeffer's trial in the 1990s, the SAVE trial. And then we had other trials of different ACE inhibitors. Valiant was a trial of an ARB, and then more recently, Paradise MI, which is sacubitril valsartan. And if you look at mortality on this axis, going back to the very first trials, this is the placebo at 36 months, 30% mortality. And then with an ACE inhibitor, a significant reduction. With two different ACE inhibitors, a significant reduction in mortality. And then the trial that compared valsartan with an ACE inhibitor that showed no significant difference at all. And that was the Valiant trial. So if you look at the trials of ACE inhibitors versus placebo, highly significant difference, but ACE inhibitors versus Valiant, ACE inhibitors versus valsartan, no difference. And then the more recent trials of ramipril and sacubitril valsartan post-infarction, no significant difference. So what can we take from this? First of all, ACE inhibitors and ARBs are highly effective in reducing remodeling, and they should be continued. Is there a role for sacubitril valsartan? Perhaps not in everybody. This was a neutral trial, but in some post-infarction patients who are sicker, with more severe degrees of failure and LV dysfunction, I think we know we can extrapolate from other trials that sacubitril valsartan plays an important role. Now, this is a study I did with Dr. Haroon Bats from the Netherlands. And what we did was we looked at, and published this in JACC Heart Failure, 2,000 STEMI patients undergoing primary PCI, Leiden, Netherlands, LVF less than 40, and that was 20% of patients had LV dysfunction. The other had an ejection fraction greater than 40%. And we looked at all-cause mortality in those patients who remodeled and those who did not remodel. And what we showed here is very little. We still show that in the modern era, there is very little remodeling. But you'll notice, and this is very interesting, that now remodeling is not predicting mortality. Whereas previously, when you demonstrated an increase in left ventricular volume on an echo, that was a bad sign. We knew those patients were going into heart failure. And compare these data with the SAVE trial at 42 months, which was the endpoint of the trial. In SAVE patients on captopril in 1990, there was a 20% mortality. You still, in 2020, get remodeling. Some patients will remodel, but it will not have an effect on mortality as it did years ago. So how do we extrapolate these data to current practice? I think the use of ACE inhibitors and ARBs is strongly indicated in all patients with LV dysfunction post-MI, and nothing has changed. But what has changed is many of today's patients have an open artery because they've had primary PCI. And I think that is an added factor that reduces mortality. So remodeling still occurs. It can be prevented by ACE inhibitors, and ARBs, and perhaps by sacubitril valsartan, but the overall impact on mortality is less than before. And I think the answer is that current therapy with reperfusion plus drugs in patients who need them, like those drugs like ACE inhibitors and ARBs in patients who need them, are still indicated. So it's generally accepted in all the guidelines that these patients need chronic ACE ARB therapy, heart failure, LV dysfunction, hypertension and coronary disease and vascular disease, type 2 diabetes with or without coronary disease, insulin resistance and hypertension. I would treat those patients with an ARB or an ACE preferentially. This is still a question. In a patient with coronary disease, normal LV function, no hypertension, no diabetes, no peripheral vascular disease, do they need ACE inhibitors? Probably not. And that's a matter of clinical judgment. Now, in the modern era, when do you start and when do you discontinue ACE ARBs? You've got to use clinical judgment and you have to individualize. You have to assess, is the patient still benefiting? What are the frequency and the tolerance of side effects? And then you need to interact and factor into your clinical decision the impact of age, declining renal function, and drug interactions. It's really a matter of clinical decision-making. Now let's move on to beta blockers. Why should they be continued after myocardial infarction? Well, we have 200,000 acute MIs annually in the US. Ischemic heart disease, the leading contributor to the burden of disease. There's a higher incidence of heart failure in MI survivors. All good reasons for beta blockers. And why should they be effective? Well, there are many potential benefits. Reduction of oxygen demands, reduced risk of VFib in experimental studies, improved diastolic function and reduction in restrictive filling patterns, improvements in the remodeling LV function, infarct size, multiple theoretical and experimental reasons why beta blockers should be effective. So what have the data been? Now, there have been 14 trials of beta blockers in myocardial infarction, long-term trials with, long-term beta blockade. And if you look at the overview from this meta-analysis from Yusuf, what you see overall is a 20% reduction in mortality. And below this line are the trials, individual trials with over 50 deaths. So several of these were large. Not every trial was positive, but in the meta-analysis, basically a 20% reduction in mortality. Now, this is a more recent meta-analysis of 60 trials with 102,000 patients by Sarup Bangalore. And he stratified them according to the trial's pre-reperfusion era, pre-thrombolysis, and those post-thrombolysis. Now, in the pre-reperfusion era, there was a significant reduction in beta blockers on 1 year mortality, reduced MI from 30 days to 1 year, reduced angina from 30 days to 1 year, all highly significant. But in the reperfusion era, when we now have more open arteries and other pharmacologic advances, now in this meta-analysis showed no change in mortality at 1 year, a reduction in MI just for the first 30 days, not 30 days to 1 year, and a reduction in angina in the first 30 days, but not after that. And the price was a higher rate of heart failure and a higher rate of cardiogenic shock at 30 days. So really a different perspective of the benefits of beta blockers in the reperfusion era as opposed to the pre-reperfusion era. Now, after primary PCI, there have been 3 recent studies, no randomized trials, 3 large observational studies. One of them showed a continued, beg your pardon, one of them showed a continued benefit from long-term beta blockers with a reduction 0.004, 8,000 STEMI patients. Another large registry study of 16,600 STEMI patients with preserved ejection fraction, no difference in 1 year mortality. And this trial from England and Wales of 170,000 patients with no heart failure and normal EF, no difference in adjusted 1 year mortality. So one presumes that probably the benefit from beta blockers in this study was because they included all comers, including those with a reduction in ejection fraction. But those 2 analyses, no heart failure, no normal EF, no benefit from beta blockers. Another large French registry ongoing, 2,679 patients with acute myocardial infarction without heart failure. If you look at 30-day survival, beta blocker in yellow, no beta blocker in orange, this is significantly reduced, a benefit for beta blockers. If you go to 1 year survival, P 0.32, not significant, although there is a slight trend. And then if you go to 5 year survival, in patients who were on beta blockers at 1 year, there seemed to be no benefit to continuing the beta blocker. And interestingly enough, they pointed out 5 year mortality was lower in patients continuing statins at 1 year. So if you were on a beta blocker at 1 year and you stopped it, there was no effect on mortality. But if you were on a statin and you stopped it, your mortality was increased. So I think that made a fairly strong case for the recommendations. They are recommended in patients with LV dysfunction or systolic heart failure. In patients with the previous STEMI, long-term oral treatment with a beta blocker should be considered a 2A. I think that's reasonable, and that's where we stand at the moment. Why is this an important issue? Why is this an important issue? We've got a growing number of elderly patients who are long-term survivors, and polypharmacy is a major cause of non-compliance and drug-related side effects. And so we now have 3 important ongoing trials. The Reboot Select trial in Spain, 8,500 patients, no reduction in ejection fraction. The Betamide study from Norway, these are revascularized patients post-infarction who have a normal ejection fraction, reduced sweetheart, the sweetheart study of 7,000 patients, and then ABYSS, which is a large trial in France, 3,700 patients. They will all be on beta blockers up to 6 months, and then the beta blockers will be discontinued, and they will be randomized to discontinuation of beta blockers or continuation. So I think we can state that the beneficial impact of beta blockers in post-MI patients with normal LV function in the current era is declining. Nothing that does not apply to patients with LV dysfunction, where we have very good and strong evidence that beta blockers are an integral component of heart failure therapy. There is a need for randomized trials, which are ongoing. And in the interim, until we get the data in the next year or two, I think you can make a case for beta blocker use for the first 30 days and to continue for up to a year. But there's probably no evidence to continue beyond a year in those patients who have normal LV function. And the trials will give us a definitive answer in due course. So obsolescence in clinical trials is a fact of life. We don't have any options but to live with it, understand the limitations, integrate the data into contemporary practice as best we can. And I do think there is a role for new trials of old drugs, but it's going to be difficult to get funding interest for this. Thank you for your attention.